Good morning, everybody. Dr. Helen Burston. I'm the CEO of the Council of Medical Specialty Societies, and thank you so much for joining us today. We're delighted to kick off our meeting this morning with a special session sponsored by our premier sponsor, Prometheus and IQVIA company. The session is Beyond Registries, the Future is Integrated Health Platforms. And I'm delighted to introduce Dr. John Morris, who will lead us off. Turning it to you, John.
Good morning. Thanks, Dr. Burston, and thanks everybody for joining live here this morning. Hope everybody's safe and well. And if you're watching this on the delay or the tape, whether it's the afternoon, evening, have your feet up. I hope you enjoy the content here and the presentation over the next 30 minutes. We're really pleased for our continued Council on Medical Specialty Societies partnership and continuing to support the work that Dr. Burston, staff, and the team are doing with all the membership around advancing the mission of the Council. So we have 4 presenters today. I'll kick us off briefly, turn it over to Shannon Shirk. Shannon and his team run all of our technology platforms and are part of delivering all the value around the data and the data-driven work that we do for our partners. Adam Mariano and David Vicola will take us through the details of the presentation, then we'll wrap up at the end and put a reminder in for a closing presentation tomorrow afternoon that Dr. Nancy Dreyer is going to be doing, our Chief Medical Officer, Chief Scientific Officer. So just a quick one slide on our healthcare business at IQVIA. Again, we have over 1,600 people that are dedicated just to working with hospitals and health systems, plans, medical specialty societies, the advocacy groups, and all of the work that we do essentially in service lines and extending disease management programs. You know, and a key common theme among all of our technology and our teams are data-driven decision-making and working to leverage the expertise and help our partners expand. Whether it's quality improvement, performance improvement, operational support, member engagement, strategy. It's a very dynamic time. It's a fantastic combination when we think here about, again, digital transformation and the challenges that we all find ourselves in today. So technology platforms, analytics, and domain expertise, when you bring that together, you can start to think about how to advance beyond registries, which is a theme of today's presentation. So with that, I'm going to turn it over to Shannon. Shannon will take us into the next step. And again, thanks for joining us here this morning. We look forward to working with you all over the next 2 days here and continuing thereafter. Shannon, to you.
Hey, thanks, John. Appreciate that. You know, we're so happy to be here and to be the premier partner with CMSS. You know, our platforms currently support over 78 registries and platforms. The teams work for many of you, and the teams work super hard for you. In fact, we've launched over 18 registries in 2020 alone, including some you may have seen on the news and in the press, like the Back to Play COVID monitoring and contact tracing programs for some folks that you may know, and we'll talk about a little later. We were planning a big splash announcement at the spring meeting, but in case you missed the memo, Prometheus Research is now an IQVIA business. We are super excited to have them on board and to join the IQVIA ecosystem. You know, we have a long history of supporting medical specialty societies and some of the largest registries in the world. So we were looking for a partner with the most innovative tech and a fantastic team, and we found them in Prometheus Research. The innovative tech and team from Prometheus are now part of the Real World Solutions team, and together we provide real world architecture, which is interoperable, based on a FHIR backbone, and scalable, and it's cloud native. IQVIA's Advanced Analytics Unit designs innovative algorithm techniques for our partners with AI and ML. And our Linguamatics business unit is an industry leader in applying meaningful natural language processing to health data. Our clinical experience managing patient encounter workflow, data quality, medical assets, and provider engagement. And then we have lots of SMEs with experience supporting hundreds of thousands of clinical providers across a large variety of regions, disease areas, and specialties. Basically, we take disparate health data in and provide actionable health information out. We, you know, bottom line with Prometheus is that we're now better together, and we're so happy to have them on board. And it's been a very successful partnership to date, and we look to further growing that partnership and our capabilities in the future. I'm very happy to introduce David Vakola, who is a co-founder of Prometheus Research and who is now the global head of strategy for the IQVIA integrated health practice. David?
Thanks, Shannon. And thank you to the CMSS community for joining us today. For those of you who know me in person, yes, my COVID hair is completely out of control. So I'm glad this will be maintained for posterity. But today, that's just one of the things that's different. And Prometheus joining IQVIA earlier this year is another of those big things that is different. But I think everyone in 2020 is essentially waking up every morning and saying, everything is different now. And it being 2020 and the fact that we're not doing this in person would probably lead you to think we're mostly talking about the pandemic. And in some ways we are. But as someone who spends their days thinking about healthcare data architectures, I can tell you that while the pandemic has certainly impacted healthcare and healthcare delivery in myriad ways, both known and unknown at this point, from an informatics perspective, COVID has really only exacerbated and accelerated the underlying trends. It didn't create them. And that's a good thing, because these modern ways of defining and measuring and treating human health are being leveraged like never before, but they're not new. Playing professional basketball in a bubble, that's new. Having multi-dimensional views of each player's health to ensure that it's safe to do so, that's actually not new. And we should know, as Shannon alluded to, when the NBA and the NFL for that matter, and even our 65,000 person parent company needed health data solutions for COVID, our literal team got those calls, not IQVIA. The folks that you're talking to today got those calls. And here's the hard truth. We didn't build a traditional registry like many of you are used to for any of them. That's because traditional registries are woefully inadequate for managing the multiple dimensions of health data that are becoming so important, both certainly during the pandemic, but really beyond. Now, as I've said before, both this morning and for the unfortunate many of you for years now, healthcare, as it's becoming more data driven, so too must the specialty societies that influence so much of what happens in healthcare. Your members and the patients in their communities are navigating what is now truly a transformational change, right down to the very patient-provider relationship. And while things like telehealth and always-on digital phenotyping, have been around for a while, they're no longer fads. They're here to stay. And yes, the pandemic gave these trends the nudge to become more mainstream, but they've been increasing in popularity for years. And these new modes of health monitoring and health interactions, they produce different kinds of data than traditional registries know what to do with. So if societies are going to remain effective and dare I say relevant in the years to come, they really need to be at the forefront of helping their members understand and utilize these data. Now, playing a leading role in this moment is going to require more than just doing things. It's actually going to require all of us to stop doing a few of the old habits that are frankly incompatible with where healthcare is going. First and foremost, and I know this is a unpopular statement, we need to stop outsourcing all the data expertise to third parties. This takes a few different forms, ranging from simple analytic partnerships to wholesale handing over data rights under the auspices of monetization, but it's going to be a rate limiter for your organizations. Both that hard-won data being generated by all your members and the skill sets needed to work with that data, they're now critical core competencies for almost any nonprofit in the healthcare space, let alone a specialty society. And I know many of these decisions are made while staring at a financial statement, but I implore you to be proactive. Don't just wait to see who throws the best offer at you. Seek out guidance from organizations that appreciate how essential it is for you to control your own destiny, your own fate. And that will increasingly mean controlling your own data. And if the first one was the least popular, my next one's probably the most shocking. We need to stop building traditional registries. No matter how fancy it may sound to connect to an EHR or do some cool reporting, traditional registries still look like this when you pop the hood. And while they're very good at measuring the specific thing that they were set out to achieve, they don't work well when you throw multiple dimensions of data at them. And they also don't work well when you come up with new ideas of things that you'd like to collect. They essentially start creating parallel pathways. They don't scale in the way that would be the most ideal. So frankly, you don't want to be the last one to build one of those old style registries when this exists today, because that transformative moment, it's going to require pretty transformative capabilities. And if you can't manage all of the data that is relevant to delivering great care, then frankly, we can't be sure that we are delivering great care, right? If we're always just viewing one small lens of a chart abstracted case report form that looks at the boundaries of an encounter or looks at one dimension of a population, we're not going to be able to get our hands around truly understanding what great care looks like, what efficient care looks like, what cost-effective care looks like. And my last piece of guidance is really to stop hedging and just embrace HL7 FHIR. Now, given that the federal government is now mandating its use, this probably shouldn't be a hot take or an abnormal take on things. But I still hear folks talking about FHIR as if it's some optional or mildly better way of doing things. It's neither. The hype has died down, but that's only because the original hype was warranted. So you know, the nerds in the group, they saw this coming, but I think the rest of us who have day jobs that don't require staring at federal regulations and dealing with interoperability probably just assume this was going to be you know, something, the next just version of what HL7 threw out there, or the next thing the EHRs companies were going to try to sell to us. But I can tell you now, having worked with it for several years in practice, not just, you know, on slides, it really does change everything, because there's a reason, and I will say there's a reason why the Office of the National Coordinator for Health IT took the bold step of actually adopting the standard and mandating it, which is something that they didn't do lightly. And for those of you who are used to mapping spreadsheets and early morning meetings and dealing with all the phone calls and the emails that say, I don't think this, you know, this is showing up correctly on a dashboard, adopting FHIR is going to be even more amazing for you, because the systems that I'm showing now, the paradigm, the juxtaposition that's up on the slide right now, we're building these types of systems for our partners today. And as my colleague Adam's going to describe in just a little while, the folks who are actually furthest along aren't specialty societies. So I think that's a real problem, because you stand at the crossroads of all of the knowledge in medicine. You have the direct relationship with patients, you have the direct relationships with the payers, you are the ones setting the guidelines, and yet folks in other, you know, your counterparts in other industries, you know, call them patient advocacy groups, call them life sciences, but you have counterparts and they are a little bit further down the path than you. So we're here today to try to help accelerate and play catch up and actually push medical specialty societies back into the lead like you were a few years ago. So with that, I'm going to hand things over to my partner in crime, Adam Mariano. We do all things strategy together, and we're happy to take your questions. Adam? Thanks,
David. So as David points out, none of this should really be new to you. We are both fans, David and I, of William Gibson, excuse me, and we've been throwing around this quote for years. And the thing I pointed out to David this week, which occurred to both of us, is while this quote is prescient, it's certainly compelling and accurate. This quote's actually 12 years old. So for any of you who believe that the future is not upon us and we are not standing in a place where we should be taking advantage of these technologies, I'm the one to deliver the difficult message. We've all sat through presentations of Art of the Possible. David and I have actually had to present a lot of them where we talk to organizations about the things in their future and where they can get to if they work really hard and they do their homework and they brush their teeth. But the reality is the technology for digital health and interop has been around for years. It's been commonplace. COVID-19 has really just been accelerating the affordability, the adoption of these technologies. And as the community seeks novel ways to extend the healthcare apron and provide access and accessibility to patients as things have become difficult and as hospital systems have had to furlough folks and change their approach to delivering care, all of these methodologies are really becoming the forefront of healthcare delivery. We can no longer wait really to see what happens. The change has already occurred, and most organizations will end up being left behind if they don't start to leverage these technologies and continue to hold on to legacy frameworks while others are embracing dynamic ways to move forward with audience engagement. So really this all exists on a continuum, and the integrated health platform really enables both retrospective and prospective EMR data acquisition. When we think about the patient advocacy and life sciences organizations, they're already doing this. They're moving across the continuum to move beyond just traditional site-based orientation and move into bulk methodologies and direct patient follow-ups through a lot of connections with health systems. Through our connections with health partners, healthcare systems, we can actually offer access to 10,000 clinical systems throughout the US. This continuum really allows for dynamic data capture and can follow the patient journey from start to finish. At the originating site, patients enroll and consent to providing linkage to their local medical records. This provides out-of-the-box access to all of the elements and clinical concepts that are within the US CDI core standard. This methodology allows for follow-up collection as that patient moves on to a follow-up visit and to see a specialist. In the example listed here, you can see the patient originating at a site for a primary visit, moving on to a follow-up visit and ultimately a specialist encounter where this integrated data could actually be leveraged and integrated with the EMR to drive both useful insight, next best action, and things like clinical decision support, and really reduce the burden on data collection. So we're asked this question all the time, which is, this is great, but what's that journey look like and how do we really get from here to there? IQVIA's integrated health platform is really core components of all of these things. We're leveraging a dynamic modular platform that offers integration and a holistic experience to patients, providers, and platform users alike. So to David's point, the experience is really a 360-degree one. Most organizations are really trying to embrace a mobile-first technology at this point. Other industries have moved on to this space long before healthcare. Healthcare always seems to be trailing just a little bit, but these novel direct-to-patient studies that allow organizations to really create compelling engagement strategies are going to become commonplace more and more every day. And they really are going to need to be in order to meet the expectations of patients and other participants. They're living their lives through their phones at this point. Telehealth has become ubiquitous due to COVID and is here to stay. There is going to be no regression to the mean on this one. And mobile strategies, mobile-first strategies are becoming a regular facet of healthcare interactions. IHP supports all of these approaches, both web, mobile, tablet, and integrated hybrid approaches to data collection and interaction. So to be successful, you really need to use a multimodal approach to data collection across clinical and IT settings. A successful modern framework leverages all of these methods on a continuum. The legacy methods that include things like CRF-heavy data collection, chart abstraction, and data uploading have run up against many barriers over time and really have only been exacerbated by COVID-19. The cost, the lack of access, heavy provider participation that's required, and the burden and overload of physicians, chart abstractors, and the like have really driven this process to the ends of its useful life. We're never going to get away from chart abstraction, but the reality is the days of it being the core methodology for collecting data are long gone. So patient-mediated releases, as we work from sort of the bottom to the top here and look at patient-mediated releases of patient information, really allows patients to share access rights directly from their own accounts. It is the next step in evolution in allowing patients to share very specific information about local hospital visits, about visits to clinics, their integrated health record that comes from Epic and Cerner. We can actually provision this record through the patient, have them share sharing rights across the spectrum, and integrate this data in both a real-time and batch setting. Legacy integrations behind the firewall things that are driven at a site level and can offer bulk upload also offer additional opportunities for automation. And there's a lot of off-the-shelf integrations that can be done there. Modern integration methodologies, and this is the stuff at the top of the hierarchy, offer significantly lower provider and participant burden and really really increase automation, therefore offering a deeper longitudinal insight. And certainly can leverage all the standard interoperability standards like FHIR and HL7. So really what we're trying to do is push more things towards the top of the hierarchy. We're moving towards automation, bulk methodologies for moving data, and then fill that in with the additional legacy methodologies of ECRF and chart abstraction. Sprinkled in the middle is the ability to surface records directly from patients. And as we move towards that edge of the continuum, the rest of the apron of data that's really critical about social determinants, patient experiential data, and other elements that are difficult to collect and often don't even exist in the EMR space are now more easily collected as part of that effort. The other idea about this is, as you think about the always-on data culture where everybody has a device of some sort, all the patient and consumer devices as well as the portable healthcare devices that are drifting out into the universe more and more ubiquitously, we can actually collect that data through these same patient-mediated endpoints as well. So if you take a good hard look at the FHIR standard, and David, I spent a little time on this earlier, more of this is less of the nerdy end and more of the practical end of this. The FHIR standard plugs into IQVIA platforms as a native plugin. We're treating this as native. Both HL7 transactions and FHIR transactions integrate to the Prometheus and the IQVIA offerings. And this really creates a velocity that's not been available historically in healthcare data. All of you have suffered the slings and hours of the difficulty of quality, inconsistency, and variability of healthcare data. FHIR really starts to put some of those things to bed. You have standard attributes and standard elements that are defined by federal standard. They use standard code sets. And we can build what are no longer one-off integrations to frameworks to pull this data in. The Cures Act puts teeth behind this, and as 2021 expands, the ramifications for not being compliant with interop, for blocking data, we're really going to be able to leverage the regulation around this to push more and more interop. The base FHIR data set, if you look at the top here, offers all the core elements in the US core data and really provides a solid baseline for interoperability. We can extend that value by adding expanded specialty and procedural data. We're able to expand the FHIR data sets, and we can do that either through negotiation with sites, through our partner network, and a lot of our frameworks. So you can take that core set and expand it to the elements that are critical to a specific registry need, research need, or project. We can also extend the value of that data by adding NLP into the framework. And natural language processing allows us to really drive insight from a lot of the unstructured notes and narratives that would otherwise be obfuscated in the medical record. We can pull significant value from those things that are traditionally lost to classic methods or require heavy transcription or copy and pasting efforts, or often importing things like PDFs and trying to figure out how to do analysis on those. And we plug those methodologies directly into our data pipeline so they can be processed through that framework. Additionally, we can use chart abstraction as a gap filling process at the bottom end of this hierarchy while the FHIR standard continues to evolve. It is by no means a panacea. It is not a silver bullet, but it does offer you a very significant lift. And we've seen across a lot of our analysis, 60 to 70% coverage in a lot of the use cases that we've been looking at from an automated data collection perspective. It's a significant jump to any other methodology that we've seen, and realistically being faced with collecting only 30% of the data you've collected historically is a significant win across what is going to be a difficult season into the winter for COVID and certainly into next year. So let's talk backbone. This is our real world data backbone. It is the framework that we use. It is currently available to all IQVIA and Prometheus partners as part of our existing frameworks and to anyone else in Q1 of next year. And it is the core of all our real world offerings. If you look at this framework looking from left to right, the sources on the left-hand side, data from the FHIR continuum that we talked about, claims data, commercial partner data, public sources of data, even things like census data, are all integrated through the validation engine and flow into that framework and are converted into standard assets. That data is stored in our electronic health information object store for curation. That object store and the way data is stored allows us to not only capture this data and standardize it, but to move to a more of a capture once and reuse infinitely methodology. So where historically a lot of institutions we've seen will build multiple registries and have to collect and recollect data, this really speaks to the ability to start to reuse some of those elements, core things like patient demographics and general diagnoses, historical visits that shouldn't be recollected. If we're collecting them in an agnostic fashion through HL7 and through FHIR, the reality is we can reparse those elements from the object store and reuse them for future studies, as opposed to going all the way back to source to try to recollect that and actually adding to the burden that we're trying to reduce. So beyond that, we move that data into the information store for curation, and then we service all of these assets with critical services. Master data management, MDM, we use that plugin to do de-identification, patient identification and match, and to unify patient records across the continuum. We use a lot of data quality, QC and QA, and constraint management in that framework. And then we use processing plugins for things like natural language processing that we talked about earlier, and to do things like tokenization for studies. We then transform these elements through mapping and assembly for specific usage. So again, this is the reuse part. So the data up to this point is, if you really think about it, is in a generic form, meaning that it can be reused for different purposes. That transform and assembly process actually converts and transmogrifies that data into the downstream assets that might be needed to be used for. So that's specific data marts, processing frameworks, eventing, downstream integration to research stores and other elements that need to be built for specific purposes. And then from that downstream, we can publish to data marts, and we can give rise to capabilities such as our cohort builder, dynamic reporting, and self-service reporting tooling and things like Power BI and Tableau. We can also service downstream consumers and data analysis pipelines, registries, direct-to-patient applications, EDC, and clinical systems, as well as a round trip back to smart on FHIR applications. So if we think about the learning health system concept, really from left to right, we're taking data in, applying processing standardization, applying historical learning. That data can then be published back into care guidelines, smart on FHIR applications, and clinical application extensions, where the learnings that were derived from this data store can be pushed back to providers in the real-time clinical setting and offer decision support. This offers really a complete end-to-end management experience that is FHIR native. So I'm gonna round trip this back to, I believe, Shannon, to wrap up our conversation here and talk about what the future looks like.
So, we get this question a lot too. The future, this kind of sounds expensive. It doesn't have to be. There's a lot of things that we can do and work with you on to talk about how to sustain and how to plan and how to mitigate your risk. And so all we ask is that, we know that 2020 has been super hard on many of you, and 2021 may or may not be any better. All we ask that is, before you make any major decisions, before you sign away all your data rights, just have a chat with us. We'd be happy to talk with you and figure out the best path forward and help you be successful in your endeavors. I know there's a few questions in the queue, and we want to get to those for you. And we really appreciate Adam and David and John for putting together such great info for us. And there's also contact information here listed that feel free to reach out to us, and we're happy to speak with you individually. But I think there's a few questions in the chat. John, would you like to grab a couple questions and kick us off there?
Yeah, sure. Shannon, absolutely. Thanks, everybody. And thanks, David and Adam. That's great. So I guess, one of the things, and as we think about kind of the setup here, and it's like I'll say to either David and or Adam, we sometimes hyphen the two of them, patient-mediated data. How does that change our approach? And if we think about, again, the new legislation and the impact of patient centricity and patient mediation. How does that start to play in? And as you think about platforms and device and content?
Adam, you're on mute. It looked like you were trying to speak, but I could take the first pass. I mean, I think you really can't overstate how much of an impact it's going to have. I mean, I think from a care delivery standpoint, providers are going to have access to more information than they know what to do with, which is the double-edged sword, right? I mean, the days of folks keeping their glucose readings on a spreadsheet and then handing it to you and saying like, look, I've been tracking this for a long time, and you saying, I don't know what to do with that. Like, those are just the tip of the iceberg. There's now going to be, I think the good news here is that through patients being able to mediate both to their providers and to research networks and quality improvement networks, direct access to that data is actually going to open up the fire hose. And when that fire hose opens, it requires technical solutions to actually process and make more sense of that data, actually incorporate it into the care plan, incorporate it into the medical record in a way that understands discovery and understands the legal impacts, understands what is actually actionable versus what's just information in the background. And so I think in some ways the influx of this data is actually going to provide much better tooling to the provider community to actually know what to do with it and how to work with it. From a registry perspective, both from a legacy registry perspective and a going forward, it offers a real, I don't want to call it a shortcut, but essentially that's one way to think about it, is that for whenever you have a data initiative in your specialty that was going to engage patients directly as opposed to always working with some de-identified population level data, you now have a mechanism to engage those patients and have them directly release that data to you, rather than having to go site by site or practice by practice and integrate, and do a full integration with their electronic health record systems, which I think all of us have seen to be very expensive to do, very expensive to maintain. And there are just some research questions, some questions in the community that don't require that level of full integration. The number of patients are relatively small. The data is very specific. And so that's where I think the biggest game changer is going to come, is that it's going to unlock a whole new class of research questions and data access to where the patient themselves can mediate, and not by filling out a HIPAA authorization and sending you a box full of paper, right? That wasn't helping anyone. So Adam, I don't know if you want to extend on that, but those are the big.
I was saying on mute, Dave, you should go first. But what I would add to that is we start moving out of constantly retrospective data into something that's nearer to real time. And so with the ability to move into direct patient access, what you're offering is a two-way dialogue. So telehealth has opened the door for this, but when we start to think about chatbots and real-time chat, the secure nature of those platforms that people are already using for banking and other things, we have the ability now to drive what is closer to real-time integration with patient data. And so to Dave's point, you've got this now huge, rich compendium of data that gives you a much more longitudinal view of your patient, their experiences. You can also now start to collect things like social determinants, living conditions, and all the other things that actually impact care, oftentimes more than even the care itself, because we're ignoring the access issues that patients have, or their living situation, or their ability to even go get a medication refill. So I think we're going to see a much more holistic approach that we've all been talking about and promising, and social determinants paid lip service to for the last 2 to 5 years. We're really at that place now where you can start to offer a much more enriched and realistic, honestly, experience for patients where they can actually have their needs met. So it's going to be an interesting year, I think, 2021.
Thanks both. One of the questions from the audience and coming in through the chat has to do with duplication of information. And as you begin to think, and as we think about multiple sources and multiple different ways that patient-centric information or provider-centric content and workflow. How are we thinking about reconciling, unique identifiers, duplication in our integrated health platforms?
This might be a good one for me to take. I spent the last 5 years or so building healthcare master data management systems. This is a ubiquitous problem. It's ever present, but it's been solved. There's between a mixture of patient identity verification and master data management, you have both the to do two things. One, I can identify you as a citizen of the world. There's enough data out there now, and through the patient-mediated endpoints, we're actually already having a patient provide you with identifiers that you can leverage. But modern master data management has always been a missing piece in registries because of the registries' disconnected nature. And if you remember, Dave showed that slide of 3 registries stacked on top of one another with no meeting points. We've made the error, I think, over time as an industry of collecting data repeatedly without connecting that data. What we're looking to help push organizations to do is you are talking to an entity. I like to think of you're counting belly buttons. So whenever I talk to a person, I'm talking to a patient who is also a consumer, who is also a parent, who may be a caregiver. They have lots of roles, but it's still one person. And we don't do a good job of mastering that person. Master data management really focuses on that. I can identify you in any real world space based on your demographics and characteristics and identifiers you shared with me. The cross-reference process that de-identifies that uses a mixture of probabilistic analysis, textual mapping, AI and ML, and all good old-fashioned lookups and third-party data sources, right? And those methodologies combined give you a way to master records on the way in. And a critical plugin you saw in our diagram is that every record runs through master data management, regardless of where it came from, regardless of your surety of its origin and provenance. And we track that all the way through from a lineage perspective and unify that data. So I think the injection of MDM as a critical core component that exists in every other industry you've ever had contact with really needs to be pushed into the space that we're dealing with from a research perspective.
Can I jump in with a question that was replicated in our chat box as well from Salam Wubu at ACP? She asked the question that I was thinking of as well, as this all sounds remarkable and definitely where I think we all need to go. What are the practical steps that specialty societies need to take to make this pivot from really Registry 1.0 to Registry 2.0? And really importantly, we've got a lot of CEOs and decision makers who are part of CMSS. How do they make that pivot in a way that doesn't discount all the work done to date and the initial investments done to date? Thanks a lot.
No, that's exactly, sure. Let me take the first pass. That's exactly the right question. And what may not have been obvious, since Adam and I both have a tendency to be the, just the most fun guys at the party and want to talk about diagrams all day. What may not have been apparent is that the right side of that diagram that Adam was showing actually had registries on them. And that's why we're kind of making a point to say, the legacy registries, stop building those as the end all, right? Like I have a single purpose. I want to answer a single question. You have a lot of those. Stop building new ones. And the next investment should be actually that pipelining, because it does two things. One, it feeds all your current registries. So if you already have existing registries, and almost all of us do at this point, some more than one, and some of them have very large financial in terms of investments and revenue, we do not want to disrupt those. What we want to do is change the cost curve, actually not for you, but mostly for your members and the participating organizations that are often paying you for access to that registry. And I think that's what Adam was most importantly talking about, is how do you change the cost curve for the folks that are funding the FTEs, for the ones that are looking for that return on investment to participate in the registry. And that's where an infrastructure like the integrated health platform supports that. It starts to change that cost curve by, if you think of that pie chart right now, some registries are 100% chart abstraction. The more we can shift that to introduce new wedges that say we're going to get this much from the US core data for interoperability, we're going to get this much from processing the notes. And as that starts moving from 100% to 50% to 30% actual FTEs, that is what's going to give us sustainability for the registries that are in place now. it's also what's going to unlock the new registries. So when we think about what are we going to do next, it's not start from scratch. It's, to the point that Adam was just making, it's saying, what is our starting point? What data do we already have? It's already harmonized. We're already answering questions with it. What's the delta between what we already know about this patient population or this provider population and what we need to actually close that gap? Maybe some of that's going to come through chart abstraction. Maybe some of that's going to come through FHIR extensions, but it's always going to be now evaluating the gap as opposed to starting from scratch. And so I think that's why I was saying, hey, stop, don't build anything new just yet. Talk to us first, because we can really, kind of supercharge your existing registry infrastructure and start changing that cost curve. And then when you have new registries, quote unquote, those 2.0 registries that you want to launch, let's change the cost curve on starting them. And when you start to move the money around like that, all of a sudden registry feasibility and sustainability models, they start to take on a very different picture. And some of the only way to make this affordable is to outsource it or to reduce the scope of it. Those discussions start to have a very different tenor.
Great, thanks.
Thank you. There is a question that came in both on, it's a combination of chat and also a theme that was presented, and maybe we can sort of tie the two together. But when we think about patient-centric content, when we think about integrating multiple different sources, we had the duplication question earlier, but the extension of that is into social determinants of health and other data elements that we know cognitive we need to begin to bring together in our synthetic view of patient-centric information. Maybe David or Adam, from an SDOH, as you think about tools, technologies, and processes to be able to extend and bring new content in, how are you thinking about social determinants of health as an example, or other similar kind of orthogonal data types?
The good part is this was what my master's in population and health was about, was social determinants in the EMR.
That's a softball, Adam. That was a really soft pitch,
well,
right?
Thank you. I appreciate it. It happens to be a topic close to my heart. My side gig, I'm a civil rights attorney. And so I'm often trying to figure out how to help people get better access to care, to extend the care apron, to figure out where the holes are in the delivery models, and to change the way people experience the healthcare system. When we look at this data, there's a lot of readily available data that you don't have to chase, that is free. There are free data sources. The integration is the harder part for organizations, but you often have great data in your data source you're not using. So when we talk about NLP, NLP used to be a sort of a pie in the sky conversation about this magical force, like in Star Wars, that could help you move things with your mind. And it's really not. It's a very pragmatic set of tools. IQVIA has a division called Lingomatics. This is all they do. NLP is so accurate at this point that they can do tumor staging and sizing from imaging and narrative notes through NLP. So we can certainly derive social determinants data from a H&P, where often the contextual conversation about where the patient lives, where you might see a scrawled note in the margin that says, patient lives alone, or struggles to get to facility, and therefore that's why they're not renewing their medication, they're not going to follow-up visits. Those are the kind of elements that you can collect from the data you already own. But then there's additional companion sources which are free. Census data, walk scores for neighborhoods, access maps about food deserts and service deserts are all critical things. The likelihood of people to own their home or own a car or live alone are all assets that we can derive from census data. And it's not identified census data. It's even the de-identified sets that give you the probabilistic idea about what people might need. And then there's plenty of survey tools that if you're already collecting data from patients, you now have the ability, like I spoke about earlier, to interact with them in real time. Would you take a 3-question survey? Do you have access to reliable transportation? Are you struggling to pay for your medications? You're seeing these questions pop up everywhere, and COVID has only driven a lot of people to more and more difficult places where they're choosing between refills and food. Those are things you can glean from easy patient mediated endpoints. And a lot of people are using their cell phones as a lifeline. It's an opportunity for us to expand that in the care apron. So I think it's a very realistic approach. There's a lot of data that's available. You don't have to pay for a lot of the data. And then there are paid sources. IQVIA has a giant data store full of data from every facet of the universe. We and our partners also have specific data if you're looking to drill down into a component, but we've been helping organizations figure out how to use the data they already own to really drive out some of these use cases.
It's really exciting, Adam. I'll just mention we have a session tomorrow specifically on incorporating SDOH and disparities into registries with Ernest Moy from the VA and Cliff Coe, who many of you know from the American College of Surgeons, as well as Karen Murphy from Geisinger. So really exciting to hear what's possible when you can begin connecting data sets. And you'll also notice that we've got a couple of our patient partners who are on asking you some Q&A. So I think this ability to really ask directly from patients what they want and need, I think is such a critical element of this next generation registries. Thank you for bringing it up, Adam.
Thank you.
That's fantastic. And maybe Dr. Burstyn, I'll follow that. One of the questions that came in from one of our patient partners again is, as we think about end use cases. So we've both got multiple sources of information integrated in health platforms. It always raises the question, how do we make sure that there aren't bad actors, bad players, or sort of nefarious use cases that sort of make their way into the utilization of that? So again, we've talked about on the inbound and from an architectural perspective, but maybe David or Adam, what protections, governance models we need to be thinking about so that we don't face the bad player, bad actor, bad use case on the utilization?
That's a perfect question given, and I think the right one, both given what we see in the news, and I think everyone should be naturally, and in some ways, this level of caution has been part of what has kind of kept healthcare a little bit in the minimum necessary world, not just from a HIPAA perspective, but also the concern to say, health data is highly privileged, and there's an assumption that as we bring it together, that increases risk. And I would give a similar answer to my earlier one to say, it's kind of the flip side of what's happening with the providers. As you introduce use cases where you now have the responsibility and the opportunity to bring together these highly privileged data sources, it requires a very close examination from a security standpoint, from a privileging standpoint. You are forced to use more sophisticated mechanisms. And I think it would absolutely be a problem to just pour a bunch of highly privileged and connected data into a legacy infrastructure. That would actually be irresponsible. But when you start talking about patient-mediated data, when you start talking about highly identified data that brings across and starts to give an essential view to improve patient care, but at the same time makes it possible for that source to tell you more things about a given person, I think it requires the analogy that I would use is almost like a brokerage account. When you think about, as you have different financial assets in different parts of the world, there are some things you're perfectly happy if people know, and there are other things that you don't want anyone to know, that you have an account here, an investment here, what your income is, et cetera, what your different sources are. And so I think just as there are certain things that require a full view of your financial picture, there are certain things that require a full view of your health picture. And that does not necessarily mean that everyone who's participating in giving you guidance automatically sees everything. But the sheer act of bringing that information together to create that holistic picture means that we need to understand, where did each piece of information come from? What is it authorized to be used for? Who is allowed to see it, and in what combination? And at any time, that individual patient, not the provider, not the place where it was captured originally, that individual patient has the right to say, I'm no longer happy with this particular use, and I'm going to rescind that authorization. And we talked a lot about the ONC's interoperability rules. We didn't talk a lot about the patient access rules, and we didn't talk a lot about the privacy rules that are now rolling through New York and California and are going to be, I think, national in the future. And they require that very granular level of privileging. So Adam can speak very eloquently to the technical kind of assurances to here's how we do this. But I think just even at the conceptual level, I think we want to be very clear that that there are models in place that offer good paradigms, and that are already in use. And I think that we should have a knee-jerk reaction to ask questions. We should try to limit our knee-jerk reaction to say don't, because the next generation of healthcare really requires going. I was at a talk a couple of years ago where the doctor said, "I've got bad news. All the easy stuff we figured out." we figured out a lot of the easy stuff about 30 years ago. Now we need to really introduce all the complex things. In order for us to do that, we needed to understand more about you than just the 15 minutes I have with you in the office. And I think that we need to find more ways to bring that together. So Adam, I don't know if you want to extend on that. I know we're running up on time a little bit, but
I would add,
it's a great question.
Yeah, I would add just a little bit. This requires two critical things. One is a really significant investment in data governance, right? Which is from the time you touch data to the time it leaves any institution, there needs to be controls on access and movement. But it really speaks to the idea of unifying the backbone of the platform, because the thing that creates the largest risk is data duplication. So in the legacy world of creating 15 different registries that collect the same data, including all the identifying data for the patient, you've now created 15 sources you have to own, manage the lineage for, manage governance and SOP process for. But also when you get a GDPR request or a privacy request or a request to be forgotten or even a request to just do an audit, you have to scan all 15 sources to get that data. And so the overhead becomes astronomical. And when you think about a unified platform, the core identifying elements for the patient are kept in a single source. They are linked through a separation, but linking, basically a loose linking to all of the capture assets that follow. And I don't replicate the identifying data ever. And so the idea is that data lives in one place. To David's point, our brokerage references full of cross-references and permissioning lives in a central store. And then the only things that are in what might be specific sources and targets are the ancillary elements that are non-identifying. They're result sets and other things, answers to questions and ECRF responses, but that identifying core can be strictly controlled, access can be granted, and we really have the ability to tighten up the process. And so it's one of the many reasons to start to modernize these platforms as we think about the digital era and the risk of exposing this data.
That's great. I'll just mention as well that we also have a session later today specifically on the power of big data, the need for responsibility and accountability that Todd Ibrahim, our current president, will moderate with Jody Daniel, who many of you know from her prior role at the Office of National Coordinator. He'll talk about the new rules that are coming into effect, I guess, next week, as well as Harlan Krumholz from Yale, who's done a lot of work in this space as well with Hugo, and then Glenda Roberts, who's a patient, works closely as part of the new task force looking at whether race should be incorporated into the GFR calculation. So really, I think a huge opportunity to take advantage of what this incredible expertise of making sure we really understand how to do this right and protect patient privacy. So thanks for sharing, obviously, great expertise in this space.
Oh, thanks, Helen. And we're not sort of tossing those out. Just there's all of the themes tie in, and they all are important for both the stakeholders. And just thinking about data governance and privacy, we've been working as a company with that through the GDPR implementations. And so historically, we saw all this coming. We've been a part of it in Europe and elsewhere. So, again, very much in the fabric of how we think about both governance, but it also puts a premium for the membership to be thinking about strategy. And strategy and governance is really critical. Not, let's go down the path and then figure it out when we get there. And I think that's something that is important for all. Just one last thing as we kind of go back and Helen, as we think about the original the whole theme of the conference, COVID-19 and beyond. Gosh, we all hope we can get beyond here as soon as possible. But digital transformation, Adam mentioned, telehealth. We've been tracking and reporting out the impact of COVID-19 on health systems. I'll throw one last piece. Adam and David, the pandemic timing, the need to be dynamic and responsive. You alluded to it, but maybe just a quick sort of summary as we think about our COVID response, which we initiated, collectively as a team. What seems like ages ago at the end of March, as we were going through this in Tennessee, Pennsylvania, Connecticut, and all the places where we currently are sitting today. Maybe the two of you quickly hit on the dynamic nature of the way you can essentially use these technologies, and sort of maybe close up on the COVID-19 response that we had, and then we'll turn it over to Dr. Burstein for one last closing thought.
Sure. I think, you know, if we're honest, and every indicator seems to be it's going to get worse before it gets better. And I think that we've watched a lot of our partners across the country and throughout the world really struggle with the downturn in staffing and the ability to deliver care. And as we've moved into the telehealth space, there's a lot of folks who are being left in the shadows, and it's minority communities, it's people without access, it's uninsured folks. And a lot of the initiatives that were in place to help drive some of that change and expanding the Medicaid apron and a lot of those other things have sort of been met with an immovable obstacle. So I think in this next 6-month period, a lot of the focus for organizations is going to need to be, how do you serve those communities that are really either got pushed out of their regular care because of the uptick in COVID cases and the refactoring of beds and facilities to treat cases, couldn't go out because of fear of exposure, didn't have access, had services turned off, and then we're drifting into the difficult winter season where that care goes down. And I think our ability to move quickly, to use patient engagement as a new tool or an expanded tool, and to really look at these methodologies is going to be first and foremost in helping us drive out care to people who are really at risk. I think it's going to be a difficult season for many, and hopefully we can find ways to continue to accelerate that access. Dave, thoughts?
Well, I would certainly agree with everything you said there. From a technology perspective, I mean, I think the stuff that we talked about today certainly helps. From everything from your classic, both the kind of legacy IQVIA and legacy Prometheus teams, had COVID registry extensions out, within a couple of weeks, for specialty societies. So it certainly helps to get that monitoring. As I think many folks know, our team actually launched the first national surveillance system with the CARE registry, and that's now being used by FDA for monitoring. So certainly there's a place for getting those signals. But I think really the real opportunity here is what Adam was describing, to actually start getting not just understanding from a care delivery perspective, what's happening in the provider community, where are the resource shortages, where are we going to have quality issues cropping up 12, 18 months from now as all of our standard operating procedures have been disrupted. It's actually, there's an opportunity here, even at the specialty society level, to start making that jump to the patient communities, or at least to help facilitate better access for the patients that we all serve, to engage, find out what's happening in those communities, start to really adapt closer to real time rather than just measure things a year from now.
Fantastic. Well, listen, I want to thank my colleagues. I think this is a great way to start off our Thursday morning, or if you're watching this on tape delay. Again, I age myself by saying it's tape delay as opposed to a digital engagement mode that you choose at some point down the future. I think Dr. Burstein and I would both love to be able to go back to the days of having 15 minutes with patients, as opposed to the current utilization and workflow challenges that we all face. But this is a very dynamic time. Put a quick plug in for, again, Dr. Nancy Dreyer, our Chief Scientific Officer, colleague, and she'll be talking tomorrow afternoon about COVID-19 clinical registries. She'll mention the CARE project, the work that we did there, as well as how we think about engaging with participants, patients, and consumers in the era of surveillance going forward as well. So maybe Dr. Burstein, I'll turn it back to you for closing thoughts on this opening session. Again, thank you from the IQVIA Prometheus team to be able to be part of this, and thanks for the partnership and continuing to work with the council. So back to you.
Oh, thank you so much for really a great opening discussion for our conference. Clearly, you've hit on so many of the themes we're going to cover over the next 2 days. So again, thank you so much. Obviously, Prometheus and IQVIA coming together was a smart move, an amazing cast of smart people able to share their ideas with us this morning. I think you've highlighted lots of work for us all to do, and we're really delighted to have IQVIA and Prometheus as our premier sponsor here at this meeting. And I think you've raised a lot of questions, and we'll have hopefully a lot of chance for dialogue and opportunities over the next couple of days. I'd encourage folks to go to the virtual exhibit hall at noon today, Eastern time. And if anybody has any further questions, we'd be happy to talk offline and connect you to the folks at IQVIA and our other partners. And with that, I believe we're good to go. We're going to reopen again at 10 o'clock. So I'm going to go refill my digital coffee mug and see everybody shortly. Thanks again, everybody. Bye-bye.